Hello friends. Nice to come back on Share Trek HIV after a little bit of a gap. And I'm very excited today because today we are going to get into a groundbreaking case and in the fight against HIV. And this is known as the Geneva patient. Now, this case offers new insights into how HIV remission might be achieved without the need for the rare CCR5 delta 32 mutation. Joining us is our co host, Raj, who has been following HIV cure research closely. So, Raj, hi, and let's get started. How have you been?
I'm fine, thanks. Nice to see you again. Thanks for joining us.
Okay. So let's, I'm so excited. I just want to ask you the very first question, which is can you tell us about the Geneva patient's background as such?
Right. So, as I start this answer, I just want to remind all our audience that I am not a doctor or a scientist, and I am trying my absolute best to read up as much as possible to bring this information to you, because all of you have constantly requested me to keep on bringing new information on HIV. So, please keep that in mind and don't be too critical of what I'm about to say. So, that said, the Geneva patient is a Caucasian man in his early 50s who was diagnosed with HIV in 1990. He had been on effective antiretroviral therapy since 2005, yet still had detectable HIV RNA and DNA in his CD4 T cells. It is said that in 2018 he was diagnosed with an aggressive type of sarcoma and underwent a stem cell transplant from a donor without the delta CCR532 mutation. And there they found positive results, and that's what we are talking about today. That's the question. That raises the question whether you can still have remission without 100% CCR5 delta 32 mutation donor.
Yes, of course. So, what role does myeloablation play in this context?
Yeah.
Or
So what happens?
and why? And also, before that, the question is like, what makes the Geneva patient's case so unique? What's so new about it?
Yeah. So unlike previous cases, the Geneva patient achieved HIV remission without the CCR5 delta 32 mutation, which is known to prevent HIV from entering cells. He stopped ART in November 2021, and 20 months later, his viral load remained undetectable. So researchers found no intact HIV virus in his DNA, and his HIV DNA levels in T cells and bone marrow dropped significantly post-transplant. So that is one of the most important aspect about this particular case. But I would also like to point out another case that happened recently, about which I made a video yesterday, which probably our audience will see before this one, is that there have been cases where there has been a case where a donor with only one parent or one copy having CCR5 delta 32 mutation donated cells for the bone marrow transplant, and the patient was successfully rid of HIV. So one doesn't need 100% double copy of CCR5 delta 32 mutation in order to have remission. Even half of that is fine, which means that earlier people with two sets of CCR5 mutation were only 1% of the North European population. So it was very rare. Now, when we talk about just one copy being CCR5 mutated, then we are looking at tenfold increase in the potential donors. They are around 10% of North European population. So it becomes much easier.
Okay. So, now what role does myeloablation play in this context?
Yeah, so myeloablation is something that I would like to explain to the audience with the analogy. Like, for example, most of our audience knows that when you use a computer, if your computer hangs, or if your computer goes very slow or misbehaves, or it doesn't connect to the Wi-Fi, it does something out of the ordinary, then the first thing that you do is you reboot your computer and everything starts working well. So myeloablation you can think of as some kind of a reboot for the blood manufacturing system or the immune system manufacturing system in the human body. So myeloablation is the process of destroying bone marrow where the precursor cells are created. Precursor cells go into the body and into the bloodstream and go to different parts of the body, and they mature in different parts of the body and become different types of cells. They could become RBC, that is red blood cells, white blood cells. They could become CD4 T cells. They could become B cells. And so precursor cells are very important, and they get created in the bone marrow. And if you have a kind of cancer in your blood, then it could be in any of those component of blood. So in order to clear that, you have to reboot the entire precursor cell manufacturing system. And that's where you want to clear out the bone marrow completely of all the stem cells and take a set of donor stem cells and repopulate the bone marrow. The process of clearing out the bone marrow of all the precursor cells is called as myeloablation. It's very crucial. And the process could also kill HIV infected CD4 T cells, potentially preventing the virus from rebounding. However, if HIV has created dormant pools in macrophages, right, then that probably would not be addressed properly, so that can always resurface. But coming back to your core question, what is myeloablation? It's the process of clearing out the bone marrow so that a donor stem cell can go and implant itself into the bone marrow and start creating fresh precursor cells, which can create fresh CD4 T cells, fresh B cells, and fresh blood cells which do not have cancer.
You're saying that as long as there are no dormant pools in the macrophages and dendritic cells, then remission is possible,
Yeah,
right?
that's my opinion as a layperson who is reading all these research for all these years as a
Mm.
non-scientist. So before any of our audience get very excited or upset about what I have said here, I would like to point out that uh, I think that the fact that some of the patients who got regular bone marrow transplant to cure cancer, even though they had HIV as well, they have recovered. So those few instances where that recovery has happened, I'm of the opinion that it happened because the chemotherapy that was done in order to complete the myeloablation not only cleared out the bone marrow, but also destroyed CD4 T cells and other cells which were harboring HIV. So possibly the HIV in those cases was not as predominant as it would have been otherwise. And they did not have any dormant pools in dendritic cell and macrophages. So when the new donor stem cells implanted and engrafted themselves into the bone marrow, it would have started creating a new immune system, a new blood cell system, and they would have killed the remaining trace amount of HIV infected CD4 T cells, and therefore the patients were free. But in the cases where that did not happen, I suspect that macrophages and dendritic cell harboring HIV might have reinfected the new immune system and reinitiated the HIV infection process. So I hope this is sufficiently clear to
Absolutely,
understand.
absolutely. I like the analogy of your laptop
Yeah,
rebooting your laptop.
yeah,
Very well explained.
yeah.
Yeah. So, which brings us to the next question, which is why is the CCR5 delta 32 mutation important? And how does this case challenge that?
Yeah, so before this case, it was felt that both the copies of the donor stem cells should have CCR5 delta 32 mutation because in that case, what would happen is the new CD4 T cells that are created in the patient's body will not have CCR5 co-receptor. And if it did not have CCR5 co-receptor, HIV would not be able to, the GP120 on the HIV would not be able to fuse with CCR5 and unleash the GP41, which has the task of injecting the HIV RNA into CD4 T cells. So the infection process cannot start. And therefore, the HIV will decay in the body and it will disintegrate over a period of time and become harmless amino acids and go away from the body. So that was the belief. So the CCR5 delta 32 mutation on both copies was the first requirement with our initial understanding of how HIV got cured with bone marrow transplant for cancer patient. Now, uh, The way I would say is that the CCR5 delta 32 mutation blocks HIV from entering cells, making it a key focus. And in previous cases, the Geneva patient's remission without this mutation suggests that it may not be essential for long-term HIV remission. And this finding could significantly expand the donor pool for HIV positive cancer patients needing transplants. But I suspect that doctor would screen the HIV patients to try to find out, I don't know how they would do it, but they would want to find out if those patients have dormant reservoirs in macrophages and
Mm,
dendritic cells. I don't know if the test exists for that right now, because otherwise this bone marrow transplant is such an invasive process. They wouldn't do it just for HIV, they would do it for blood cancer. So in which case, it's already a proven fact that blood cancer gets cured with bone marrow transplant. So if a person had HIV and blood cancer, it's worthwhile to
mm,
do the bone marrow transplant. And first, they can try to look for 2 copies of CCR5. If they can't find, they can look for 1 copy of CCR5. If they don't find that, then they go for normal, because at the very least, the cancer will be cured, right?
absolutely.
And if HIV gets cured, it's a bonus. So that's the
That
way
was
I'm
very,
thinking.
very beautifully explained, Raj.
Thank you.
So this is really a breakthrough case indeed.
Yes, I think so. Yeah.
So my next question to you is, what implications does this have for future HIV treatments?
Right. So if early myeloablation before HIV infiltrates macrophages and dendritic cells and proves effective, it could revolutionize HIV treatment. This approach would shift the focus from needing specific genetic mutations in donors to timing and thoroughness of the pre-transplant conditioning process. It also emphasizes the need for more research to understand why some patients achieve remission while others do not. So I recollect when I was speaking to Jeff Galvin of AGT,
Hmm,
uh, I was asking him, when you take donor cells from HIV patients in order to create AGT103-T, where you're removing the CCR5 co-receptor, do you check for cells, whether they are infected or not, and remove the infected ones and use only the uninfected ones? So Jeff said there is no test to find out whether it is infected or not. So I'm thinking that the next avenue of research probably would be to find the surface markers on CD4 T cells, dendritic cells, and macrophages, which are infected with HIV, so that we can have some tests to identify which cells have got infection and which do not, regardless of whether they're dormant or active. So once we are able to
abs-
do that, then I think we will be in a position to start using regular patients' stem cells for as donors and cure more people. Because once we are able to identify these infected cells, then we could have some special delivery program using CRISPR-Cas9 or something to go
hmm,
and change the PD1 or program death one indicator in those cells and get the natural killer cells to kill those infected cells. So the possibilities are amazing, right? So
hmm,
that's one avenue of search. The other avenue of search would be to find out some way in which these patients can be supported by some kind of conditioning agent which can work on macrophages as well, so
hmm,
that regardless of whether they have dormant cells or not, anyone who goes for a normal stem cell transplant will continue to get cured. So these are all looking like a pie in the sky at this point of time and wild speculation. But I'm sure that scientists across the board who are trying to make breakthroughs would have thought about these possibilities, and they would have started thinking about how they can create experiments and trials in order to identify these things. First, it may happen on a preclinical basis in a petri dish, and then they may go into some kind of clinical trial with tools. So
hmm,
diagnostic tools, I think, are the next area where progress
hmm.
has to be made for us to have breakthrough, so that we can use normal stem cells from regular donors to cure HIV patients with cancer and HIV. I don't foresee in the near term bone marrow transplant being a standard of cure for
Hmm, for
HIV
HIV.
patients who do not have cancer.
Hmm, hmm, hmm. So I'm very curious to know, and I'm sure our viewers also would be very curious to know, what are the researchers saying about this case?
Yeah, so the way I understand it's based on all the uh, all the press releases and various documents that I have read, it seems that the researchers are excited but cautious. They acknowledge that while this particular case is promising, continuous monitoring and further testing are necessary. They are particularly interested in the roles of myeloablation, graft versus host disease, and immunosuppressive medications in eliminating HIV reservoirs. So I'd like to just briefly explain graft versus host disease because the viewers in my other channel, Genomic Investment channel, are very much aware of this. But here, I don't think I've discussed this very often. So when any organ or bone marrow or anything is transplanted from a donor into a patient, there is what is called as graft versus host disease. Graft is something that comes from outside. Host is the one into whom it goes. So there's a fight between what came in and what is already in the host. So that's why it's called as graft versus host disease, because the host immune system will fight and kill anything that comes into the body. And what is coming into the body in case of bone marrow transplant is first myeloablation is done to kill and clean up the bone marrow. And then we have the donor stem cells coming in. And we want the donor stem cells to have a free path to go all the way to the bone marrow and get engrafted and start creating new cells. We do not want the host immune system to start fighting it. If it starts fighting it, that's where you get graft versus host disease. And that's very dangerous for the patient as well. That's why immunosuppressives are used. So after myeloablation, when the stem cells are going to be introduced, immunosuppression is done. And that is one of the reasons why it's not recommended for HIV patients. It's recommended for blood cancer patient, the stem cell transplant, because this is very, very invasive. I have read the case of sickle cell disease where bone marrow transplant has been allowed. In sickle cell disease, the patient gets what is called as VOEs. These are vasculo-occlusive events. They are very, very painful. The blood clots and blocks various areas in the body, and it's painful, and they need to get a transfusion. This may happen 2 or 3 times in a month for some patients, and it may happen once in every month for a patient. So every time they go for the blood transfusion, they have the risk of blood-borne diseases like hepatitis B, HIV, STDs. All those things can happen to them. And they cannot reliably go to work. So productivity is lost. So they are suffering so much on a daily basis. Their life expectancy is also shortened. So they are given bone marrow transplant, and the new blood cells that come, they help the patient. And therefore, it's allowed there. In case of cancer, I said blood cancers are cured with bone marrow transplant. So in those cases, it is allowed.
So sickle cell is also treated with this with the
Yeah.
stem cell thing. Okay.
Yes. Yes.
Oh,
So there are 2 types of treatments. One treatment is to take the patient's own cells, make modification, and put it back. That is called as autologous. The one that is right now in the market is autologous. The other method could be allogenic, where you take a healthy patient's stem cells, make the modifications, and introduce it into the body. So both methods are available. Right now, autologous methods are being used because that helps prevent having graft versus host disease and immunosuppressives. But it involves a lot of extra work. Patient will not get the product as soon as they need it because they have to first donate their blood, and then the blood has to be processed and then modified, and then quality control, multiplication, and then reintroduction into the body. That whole process takes time, efforts, and resources. So that's the problem with autologous. With allogenic, it's readily available off the shelf. So as soon as the patient is diagnosed, they can give a prescription. You go to the pharmacist, you bring it, and it's put into the patient. So in those cases, immunosuppression and graft versus host disease tackling is done through genetic engineering on the product itself to make it invisible to the immune system, or immunosuppressive regime is given so that it can facilitate. So that's the answer.
Now, what are the next steps in research based on this case?
So I am suspecting that future research will likely focus on validating the findings from this case and trying to come up with ways to confirm if this is an exception or a freak event, or is it something which is normal, or is it something which can happen in 50% of the cases or 60% of the cases, so that we can reliably tell patients what the outcomes would be. So that is one part. And also finding whether early intervention before HIV reaches macrophages and dendritic cells can achieve similar result could be one potential avenue. And I also suspect scientists might be looking into gene editing techniques like CRISPR to delete or disable CCR5 receptor. We already know AGT is doing that with AGT103-T. They are disabling the CCR5 receptor. And so those are the activities which are going on. So apart from
So
that, yeah,
I had one question,
yeah,
Raj, actually. Now, is there some specific time in which the HIV reaches these two areas, the macrophages and dendritic cells, or it can be different for different people? There is no
yeah,
way to know how a
yeah.
human body would behave.
There is no
You
way to
know.
know it. It could be different for different people. For example,
Mm,
like men sleeping with men, for example, they are most likely, I suspect, to get it through dendritic cells.
okay.
And when there's a man-woman couple, they are most likely to get infected in a different manner. So
Okay.
that is one
There's no
possibility
way
out
then.
there. Some people may get infected because of infected syringe or something like that, like drug users, for example. So the methods are different.
Mhm.
The random part of it is that macrophages are constantly moving around in the designated area of the body where they are. They are all over the body, and if they
Mm,
come across HIV, they could digest it and throw out and show a antigen on the surface if they succeed, which can create a whole lot of immune system with CD4 T cells, which are suddenly no longer naive and start creating antibody. So that could happen. On the other hand, macrophages have CD4 receptors, so HIV could infect the macrophage before the macrophage can destroy the HIV, right? So I think that from based on whatever little I understand of the whole process of human immune
mm,
system, I suspect that it's a matter of luck whether your macrophages and dendritic cells are infected or not. So that's how I would phrase it.
So, Raj, today has been a very wonderful discussion. And just when we were thinking that this disease has no cure, and
Yeah.
suddenly this Geneva case comes up, and I was so excited to hear about it when you first spoke. I really wanted to know more, and all the beautiful explanation that you've given throughout for all the questions has really kind of increased my knowledge as well.
Yeah.
And it's really heartening to note that there is a ray of hope. And research probably, as you say, would go around developing better diagnostic tools and things like that, right? So this is a huge beacon of hope, if I may say that.
Yeah, I also think so. And before I could conclude, Maha, what I would like to say is that I've used the term Geneva patient. The scientists are still not yet named the patient. They are
Okay.
calling him the German patient in honor with the first patient who got cured this way. So we'll have to wait and see what the name is going to be. But for the purpose of today's video, I use the term Geneva patient,
Chennai.
just like that.
Okay.
So that's one thing I would like to mention. And I think that in our channel, we have been trying to give as much information as possible to diverse audiences. And there are a lot of audiences from India who are
Hmm.
unhappy that we don't do Hindi videos. So I would like to point out to them that within 48 hours of publication of any of our HIV videos, there is Hindi subtitle, there is Turkish subtitle, Thai subtitle, Filipino subtitle, French subtitle. There are around 14 or 16 languages of subtitles that I do. And it takes time to put the subtitles. It takes YouTube certain amount of time to create the original subtitles. And then I have to correct those subtitles. And then I have to get YouTube to translate them one language at a time. So all this takes me around 48 hours after publication. So I would ask them to bear with me and use the subtitles to understand what is being said. And the other thing I would like to say is that my mother tongue is Tamil, but
Hmm.
I have been trying to do Hindi videos. I did a lot of Hindi videos earlier to reach our audience and make it easy for them, right? So if I can speak Hindi and explain it to them, then I would expect that any Indian person suffering from HIV, whatever their language might be, can do a little effort to read the subtitles. And if they don't know how to read Hindi, they could at least start learning how to read Hindi and start learning how to read English subtitles. So somehow or the other, they would be able to understand what I'm saying. But if they want me to
True.
do everything into Hindi, I don't have the time because I have other things to do. I have a family life, and I personally cannot sacrifice the entire life of myself and my family just to keep on sitting in my studio and coming up with Hindi
True,
video
true.
after Hindi video. So there have been some audience who have been
And
very
come to think
abusive.
of it, Raj, there is a lot
Yeah.
of research going into this. You cannot just come into a channel and speak about something, and this is a medical thing,
Yes.
an issue, and we are not doctors. So
We are
you
not
have to
doctors.
do a lot of research. Go in, I don't know, so many. You have to read so many things and
Yes.
come prepared before you talk about it. That's a huge risk.
Yes. And
You
also,
cannot just can't
yeah.
make a mistake there.
Yeah. And I have found that I had Spanish audiences asking me for Spanish, but they said Spanish subtitles. They're happy with Spanish subtitles. For some reason, the Indian audience is treating me unfairly because I am of Indian origin, and they are expecting me to speak in Hindi. I can speak in Hindi in Zoom calls because if they ask me a question, I can answer it in Hindi. But creating a YouTube video for a HIV topic is a very different thing altogether
And
because
moreover, like you said, they're all medical terms which don't
medical term,
have a Hindi
Hindi equivalent.
whatever
They don't have
synonym,
a Hindi
right?
equivalent, and it takes
Oh,
me
this is
time to translate. So when I'm reading my teleprompter, I need a teleprompter for the English version and the Hindi version so that I stay on the point. So when I'm go
correct.
through it, I have to translate it on the fly, and suddenly I come across a term like myeloablation. How the hell can I explain myeloablation in one word to my Hindi audience? And then there are people from villages. Even after I do all of that, they will put in the comments, "Sir, ye kya hai? Sir, wo
Hmm.
kya hai?" Those kind of questions like, "What is this? What is
And
that?" And then I have to explain it in the comment. I do not have the bandwidth to do all of those things, right? So I would expect that the Indian audience who do not speak English start reading the Hindi subtitles because I'm reaching out to them that way. And I hope that they find value because we're making fantastic videos out here. And those who start reading the subtitles will find it very entertaining and illuminating. Because I would say that I'm not doing research, I'm reading research papers in order to understand.
absolutely,
And I consult various places to understand the terminologies to make sure I'm giving you the right information. And this is the best I can do. But if I push myself more than this, then I might break down. If I break down, then I may not be a YouTube content creator. And
absolutely.
that is not what I want to do.
So you have to create a fine balance with
I had to
you
have
know
balance.
your personal life, your
Yes.
social life, and then a
Yes.
YouTube channel.
Yes, so this is
So
the balance I have.
has
So
to
I
be
thought I'll take the opportunity to explain that as well. So the world is getting better with this HIV, and with AI coming in. I'm thinking in the near future, AI is going to play a bigger and bigger part. It's already doing in proteomics, and proteins are the currency of the body. And I think with proteomics through AI can also come up with some ways of creating ART and HIV control and HIV cure. Look forward to that day. So
let's hope. Let's
yeah,
hope.
so with that, I think I
Yeah.
would like to bring this video to an end. Thanks for interviewing me, Maha,
Thank
and
you.
helping me
Thank you,
bring out
Raj.
all the information.
That
And
was a wonderful interview.
yeah,
Really enjoyed asking you the questions and
yeah,
wonderful case that you brought to the fore.
yeah,
Thank you so much.
yeah. And big thank you to our Patreons and members who have been supporting the channel because our HIV channel doesn't get much ads. And it's the funding from the members and Patreons that allows me to have my subscriptions for the various tools that I'm using to create these videos. So thank you very much. And please subscribe if you haven't subscribed, and send this channel to your friends and ask them to subscribe. Help us get to 20,000 subscribers. Thanks and have a great day. Bye for now.